Hello, everyone. Just while we're waiting, if you don't mind putting what year you're in the chat, it would be really helpful. Thank you.
Hi everyone. Oh, sorry, I don't know why there was a bit of backlash, but yeah, we are about to start the lecture on the ABCs of being a junior doctor. We have the lovely junior doctor with us today from England. She knows all about it. She has been working in the field. So we're just going to get her take on some scenarios and interview type questions whenever you're ready.
Hello, everyone. For those of you that don't know me, my name is Taranpreet and I graduated from LF1 last year. I'm now working as a junior doctor in England, and I thought I'd run through some scenarios because I think you've all done a lot of theory, and thank you for letting me know what years you're in, just so I know how much to expect. I'm hoping to make this quite interactive, so please do respond or I will have to pick on people. Just going through, I'm going to run two scenarios through. One of them is going to be something that I had to deal with last week, and one of them is going to be a scenario I was given in an interview for one of my F1 jobs. So just, I know there aren't many final years here, but it's just good to have an idea of what kind of things come up in interviews and why it's important to think about things in a particular way. So how many people know about the ATE assessment? If anybody wants to speak up, put it in the chat, that's fine. Otherwise, I'll just run through it. I think it's a good place to start. I'm not expecting everybody to know what it is. I just thought some of the more senior students here might. So I'll give you a minute to potentially respond in the chat, or just feel free to unmute and talk it through. No? Okay. So the ATE assessment is essentially a way of approaching unwell patients, and it's just to make sure that you rule out all of the life-threatening things first. So you literally go in the order of A, B, C, D, E. So A is the first thing you do, is you'll check the patient's airway. Then we'll move on to B for breathing, C for circulation, D for disabilities will include things like a VPG, doing a blood gas, making sure there's nothing in the history that you're missing. And then E is everything else, which is essentially fully exposing the patient, making sure that there's nothing you've missed and nothing else you should be working on, or any other obvious signs. So for example, if you think a patient is anemic and you find out they're bleeding from their leg in vast quantities out of an artery, that would come under E. Okay, so we're just going to start straight away. I'm not scary, I promise. There is no such thing as a stupid question. To be honest, if you think the question is stupid, somebody else is almost definitely wanting to ask it. And this will work a lot better if you're happy to chat through it. So you walk onto the ward in the morning. This is the situation that actually I dealt with last week, just for context. You walk onto the ward and the nurse says, oh, the patient in bed 4 is a little bit drowsy. I'm not really so sure. Can you review them first on the ward round? So who would like to volunteer what they feel they should do next? You can message me privately if you'd rather I read them out, or I'm happy people just to unmute and chat through. I will start picking on people now that I know what year you're in.
Would you check their vital signs and see how conscious they are, maybe do a history and a clinical exam?
Yep, so that's, I think that was Fizza or somebody else, I don't. But that's a great idea. Would you go straight to the patient or would you do something else first? It's not a trick question.
I would have a view of the surroundings and how they look from outside and then go to the patients.
Yeah, that is a great way to do things. The other option is you can run to the computer and check their labs. Somebody said in the chat that you check how they were doing overnight, and they were really good suggestions. So from all of that, oh, my animations aren't working. That's very sad. So essentially you go to the computer and this is the information you get. So a news score is a cumulative score that tells you what the patient's vitals are doing, and the nurse has just taken this assessment now. The EPMA is the online prescribing tool that we use in my trust, and these are the medications that they're on. We've got a few more junior students with us. So FE is iron supplements, furosemide is a diuretic, omeprazole is a stomach lining, PPI, apixaban is a DOAC to prevent clots, bisoprolol will reduce your heart rate, tamsulosin is for urinary symptoms of BPH, and vitamin D is, as you know, for bone health. Does anybody know what this purple thing on the right is? Again,
it's a respect form.
Yeah, and why is a respect form important?
They basically indicate whether the patient has a DNR or not.
Yeah, precisely. So why do you think this is important in this scenario?
I'm not sure. I just joined, to be honest.
So it's just if a patient's unwell, as well as the respect form stating do not resuscitate, it'll also give you what's called a ceiling of treatment. So for example, someone could be not for resuscitation, but still, for example, for intubation and still for ICU support. The other alternative is what we see most often is for a ward-based ceiling of treatment. So this means you need to think about the patient wouldn't be for ITU escalation. So any interventions you do need to be able to be managed on a ward setting. So you can't intubate someone and take them to ICU if their respect form says that that would not be appropriate. So it's just something to bear in mind. Is there anything else you want to know that isn't on the screen? There is no such thing as a stupid answer. And again, I'm happy for people to message me privately in the chat and I can read it out if that's better for you. Oh, someone asked a question. Everyone has a respect form. Most elderly patients on a hospital ward should have a respect form. If you can't find a respect form, you would assume that the patient is for full escalation and for full CPR. But there's a movement now towards whenever you admit patients and quite early on in their admission to start having these conversations so that you're not having to have them in the middle of the night when the patient does become acutely unwell. So We are going to pick on Mark only. Is there anything else you think we should know, Mark? You can message me. This is going to be really boring if I have to talk. Okay, not that you can think of. That's fair enough. If the patient was really unwell, I would just go and see the patient straight off. If I had a bit more time, I would flip through and find out actually why was the patient admitted? What's wrong with them? Yeah, perfect. Someone says patient history journal. So this is an 84-year-old man who was admitted with a chest infection about 2 weeks ago, had some antibiotics, had some nebs, he's doing a lot better, and actually he's medically stable and he's just awaiting his care home to be prepared. This is technically a well patient who has now deteriorated to some extent that you don't know. So you're slightly more worried than you were before, okay? So we go forwards. So it would be great if somebody wants to go through the ABC assessment and the answers will come up. Or I'm happy if you just go one at a time and stick a message in the chat if you don't want to say it out loud. I get it. These are scary. I'm not scary, I promise, but this is where we are. Please don't make me pick on people again. That was really mean. And I'm sorry, Mark. And if anyone has questions or you'd like to go back to the vital signs, that's also fine. Perfect. Start with airway. So what do you want to know about the airway? Exactly. So the airway is patent. Patient is, however, groaning and potentially snoring a little bit, and you're not so sure about that. What would you do next? So he's not talking. That's a really, really good point. He hasn't responded to you at all. You've kind of walked into him, said, hello, I'm one of the doctors. How are you doing? Here to look after you this morning, and he hasn't responded at all. Does that change what we're thinking? Okay, someone said breathing. So his chest's clear. You listen to his chest. He's got good breath sounds on both sides. Looking at him, he looks a little bit short of breath. And if we go backwards, you can see on his sats, technically he's not tachypnic because 20 is within normal range, but 20 is right at the start. And as someone said, O2 sats, 95% is technically okay, but it's pretty borderline. So we're not hugely happy, but technically he's all right. He's still not said anything to you, no words. What would we do next? GCS is a really good idea. Calculating a GCS can sometimes take some time, and I wouldn't necessarily do it at this stage. I'd use an AVPU scale. Does anybody know what the AVPU scale is? Okay, so the AVPU is the shortcut to GCS, and it's essentially explaining whether the patient is alert entirely, responsive to voice, responsive to pain, or unresponsive, precisely. So I would say the patient is kind of responsive to voice. I'd put him as a P on this scale, and I would think, yeah, I should probably calculate a GCS, but I don't think that's critical right now. So we'd go on to C. And this is really shitty junior doctor shorthand that you'll see written in the notes a lot. Basically means heart sounds 1 + 2 + no murmurs. That's normal heart sounds. His radial pulse was present but weak on palpation. His ECG shows AF, which actually is long-standing, and that explains why the patient was on apixaban. Capillary refill time was more than 2, which means he's got kind of a slow circulation. So at this point, I think about doing a blood gas. And if we just go back to the patient's vitals for a minute, oh God, we can see his heart rate's a little bit high and his blood pressure is a little bit low. Does anybody have any suggestions on that information? Looking particularly at his blood pressure and his heart rate. Anybody thinks of calculating a shock index calculation? Or just kind of looking at it and going, that's a low systolic and that's almost 100. So we potentially could be dealing with shock here. That doesn't really explain why the patient's not responsive, okay? So going forward, we'd look at D. And in D, what I tend to check is the abdomen and the blood sugars. Patient looks quite pale from the end of the bed. He's a bit cold, just generally doesn't look very well. His abdomen is soft throughout. And because he's not really responsive, you're not 100% convinced it's non-tender. He's not jumping off the bed, but he does seem to be pulling some faces and trying to push your arm away when you palpate his abdomen. Blood sugar is normal. So going forward, we'd go on to E. So PEARL stands for pupils are equal and reactive to light. They're a little bit slow to respond. He's responsive only to voice. So as somebody mentioned earlier, with now think about calculating a GCS. And it's show that. Okay, there's meant to be a picture here that comes up with GCS, but there is not. So who knows how to calculate a GCS? Most junior doctors would not be expected to calculate a formal GCS at this stage. The AVPU would be enough for a handover. And because the patient is only really responsive to pain, it would be appropriate not to take the time to calculate a full GCS. In this example, I'm going to tell you that the patient has a GCS of 7. That's 2 for eyes, 3 for motor, 2 for voice, because he's kind of groaning. He's flexing to pain. He's not really opening his eyes. Not a well patient. Does anybody have any suggestions of what you do now? You're standing in a room by yourself with a nurse and a patient. What would you want to do now? And does anybody have any differentials from what I've said so far? Yeah, that's a really good point. The GCS is low, so we are at risk of airway compromise. But do you remember how I said that on the respect form, it's not just about CPR? So this patient is not for ITU escalation. This means that intubation would not be appropriate. Is there anything else you would consider? Or would you still ask a senior? And is there anything else you think you should check? Mechanical ventilation. The patient's not for escalation. So you wouldn't really put them on a ventilator if it's not appropriate to send them to ITU and you can't ventilate them. I've put blood gas on the slide and I haven't given you the results of the blood gas. So while you're doing your assessment, in C, you ask the nurse to take some blood, send off some formal bloods and get you a VBG. So on the VBG, you get back his electrolytes are normal, his acidemia is normal, but his hemoglobin's about 50. Does that change anything? And Ravati's made a really good point about senior review. At the moment, you're just an F1, standing in a room by yourself. What would be a really good thing to do? Hey, someone's call for help. That is a great suggestion. So what I did at this point is called for help. I rang the medical registrar on call, who said, do a PR, send the formal bloods back and read me out the gas. When I read out the gas, he said, okay, consider a CT head. Is the patient bleeding into his brain that we don't know about? PR stands for per-rectum examination. Is the patient bleeding from his bowels? And that's why, because his hemoglobin of 54 is very low. And actually, hemoglobin that low could explain the patient's consciousness being reduced because his brain is not being adequately perfused. The other suggestion would be, although his SATs are good, if he's that anemic, he's not being well perfused, could you get some oxygen? The ward you're on doesn't have oxygen. So the first thing you need to do is try and transfer the patient, but work out if he's stable enough to transfer. And something a senior told me, and that I think everybody should do, is as soon as a patient is unwell like this, and you're calling for senior support and thinking about transfusing or giving fluid boluses or giving him some blood, get 2 big cannulas in, one in either arm, because the more shut down this patient becomes, the harder it's going to be to get a line in. Okay. So it is slightly scary, but the point of this is that there's always somebody you can call. It can be the medical registrar on call, and if you are the medical registrar, you can call ITU. Even if the patient isn't for ICU escalation, ICU will still be able to advise on further management. So one of the discussions I had with one of the intensive care nurses was, okay, it's not appropriate to intubate, but putting a nasopharyngeal or oropharyngeal airway in will protect the patient's airway whilst we're working out next plans. We also ordered some blood to try and transfuse the patient to improve them. Okay. What's more important now, the PR or the CT head? And this is not a trick question. Any takers in the chat? Okay, someone said CT head. A lot of people have said CT head. Okay, I agree that a CT head is a important test because if patient's bleeding into their brain, it is an urgent problem. However, you've got to book the scan, move the patient to the scanner, and get the patient through the scanner. So something I have found is quite difficult to get used to is when you're working on your own, you have to work out what things can be done quicker. So actually what I did is I requested the CT head on the computer, got the nurse to call the department to make sure that the patient can be taken down. And whilst that was happening, I did the PR. So it's all about trying to do things in tandem because yes, the CT head is urgent, but the urgency of CT head is still going to take a minimum of 15 minutes to get done. Just for the pure fact of getting the patient onto a bed to the department through the scanner and back. So you can do a PR in the meantime, it takes 2 minutes. So you roll the patient on their side with the help of the nursing staff. You go, oh yeah, he had quite a tender abdomen yesterday and we had to catheterize him because he hadn't opened his bowels. You kind of go, okay, that's a bit weird. You remove the patient's pad because he wasn't able to mobilize the toilet fast enough. So he's just been given a pad in case he has an accident. And you notice that there's frank melena in the bed. That, yeah, someone's just said it in the chat. If the PR is enough to drop the HB, wouldn't it be a noticeable bleed? Yes. But until now, you haven't pulled the covers back on the bed. So once you pull the covers back, you kind of get a bit of a smell and you think, oh, that does smell like melena. As soon as you take the patient's pad off, there's approximately 2 liters of frank melena sitting in there. At which point a PR is no longer necessary and you are treating an upper GI bleed until proven otherwise. Does anybody know what the treatment is? I'm not expecting you to know, this is just bonus points and I'll be very impressed.
For melena, right?
Yeah. So the answer is IV omeprazole until you can get the patient stable enough to go to endoscopy. So essentially what you have to do is, and this is why the 2 cannulas, one cannula has IV omeprazole high dose as an infusion running through. And with the other cannula, you're just transfusing blood to get them stable enough to withstand an endoscopy. Okay. And that's not a decision that you would be expected to make as an F1. You would just be expected to recognize the problem. And exactly as Kedar has said, if the HB is dropped that much, there's got to be a big bleed from somewhere. You've just got to find it. Okay. And if you tell a medreg this patient is really unwell, they're not responsive, they've dropped their HB and there's frank melena in the bed, they will come. So you have stabilized the patient. Congratulations. Handovers are really important. We'll talk about documenting and updating the family in a second, but these are the things that you are expected to do well as a junior doctor once the patient is stable. You're not expected to treat the ongoing bleed and manage the omeprazole doses and do the endoscopy and fix whatever bleed there is, whatever ulcers are found. Your job is just to stabilize the patient, get help, and then work through the longer term treatments. So SBAR is a handover tool that we use a lot, and it's a good way of giving a succinct handover. So you explain the situation that you are currently in, the background of the patient, your assessment of how unwell the patient is, and your recommendations or requests, okay? So I'm going to do this one, and for the next case, I'm going to either pick on one of the senior students or hopefully somebody will volunteer to do the next SBAR, okay? So I've moved the patient to another ward because they were on a ward that didn't have oxygen and the nursing staff needed a bit more support. So when I'm handing over to the ward team, I'd say, okay, look, it's an 83-year-old man that has become very unwell. He became unresponsive this morning and had a HB drop from 120 to 50. He's got Frank Molina. I've started him on IV omeprazole, but he's very unwell at the moment. Patient was previously medically safe, and although he does have a respect form not for ITU escalation, because this is a reversible cause, we are looking at doing an endoscopy, and the medical registrar will be down soon if he's not already here to talk through next steps. I think this patient's really unwell. I've prescribed however much blood I was able to give, and we're trying to run rapid transfusions. I think this patient needs regular OBS and regular medical reviews to ensure that he doesn't deteriorate further. I'd recommend 2 hourly OBS and a senior review in the next 2 hours with the view to transfuse more blood. Okay, so it's really simple. This is a case that I actually did quite a lot before I handed over, so it was quite a long handover. But if I was at a case where a medreg had turned up when I was still doing my A to E, my SBAR could literally be, this is a really unwell patient. He's unresponsive. I've noted a HB drop and seen Melina in the bed. The patient was previously medically safe for discharge and awaiting a package of care. However, he does have a respect form not for ITU escalation. I think the patient's having a lower GI or an upper GI bleed, and I'd like your assistance. The recommendation or request, the request can just be, I need some senior support. Okay, you don't have to give a treatment plan. In terms of documenting, I will always try and document in an ABCD pattern, because you are less likely to forget something if you document in the order in which you do things. It's also just a really good way to make sure you don't miss out something urgent or important, but you'll pick up your own way of documenting as you go through. Updating family is something that I think as juniors we often forget about, because it's technically not a medical job, but it is your responsibility to make sure that the patient's relatives are aware if there has been an acute change or an acute deterioration in their status, especially if they were considering taking them home. Okay? I'm sorry if that was a bit full on. I just think we're very good at theory, and actually when you're presented with cases, you have to think through the logistics a little bit more. Okay? Going to go straight into the second case. I'll give you all a minute's breather. The second case is a case I was given an interview, and I got some feedback from this particular interview on how I approached the case. So I'm going to alter the answers given slightly to be the perfect answers, because I think that's more beneficial to you. I think if and when you do come to doing interviews, always asking for feedback, the worst thing they're going to do is say no. And any feedback you get will always be helpful. Okay, so I'm in an interview, I'm super stressed, I've gone through my whole CV, and now we're doing a clinical case. This is what I get told. You're walking alone in the hospital one evening and you come across a patient that stumbled in, looks rather disheveled and disorientated. The patient then stumps on the floor. And that is all the information you're given. So what would you ask the person giving you this case? What more information would you want? Age. Great question. Patient's looks to be in their early 30s, late 20s. Okay, they're in street clothes. You don't know anything about them. They're not dressed as a patient, but they've stumbled in, and you're the only doctor there. Somebody said journal. I'm not sure what that means. History of the patient. Okay, so you go up to the patient, you introduce yourself. Say, hi, my name's Taranpreet, I'm one of the doctors. Are you all right there? And they just kind of groan at you and slump to the side. Are they safe to approach? That's a really, really great question, especially if you're in a city, especially if it's late at night, especially if you are concerned that you're on your own, you're a female, you're in a corridor. You can always call security. If you feel the patient's safe to approach, you can do so, but you're well within your right not to approach them. Okay? So we've got a 30-ish-year-old who's come in looking a bit confused, stumbled, looking disorientated, and is now slumped on the floor. That is all of the information you've got. What would you do next? Are you happy managing this on your own? Are they bleeding from any orifices? No, you cannot see any blood from where you're standing, about an arm's length away from the patient. Perfect. Somebody said, check the airways, breathing, and shout for help. Exactly what I said. The patient does have an airway. They are trying to say words, but they're not making a huge amount of sense. Their breathing is shallow and rapid, and you've asked for help. Hopefully someone's coming soon. Anything else? Anything else you can do on your own? So they are responding. They're definitely responding to voice. I'd put them at a V. They're alert, but they're just not really answering questions. They're more just slurring and groaning. So ABC, go on then, why don't you run through the ABC? So airway is patent and own, protected. Breathing, I've said, is shallow and quite rapid. In terms of C, what can you do if you're on your own?
CRT.
CRT is a great answer. The other thing is check a pulse.
Yeah.
Yeah. So the radial pulse is fast, a little bit weak, but not terrible. You're not going to get a number. You're not going to have time. So a nurse turns up. So I'll let you have some help. And says, all right, what can I do? Oh, somebody said call the emergency CPR if they don't respond. Calling an emergency, yes. CPR if they don't respond wouldn't really be appropriate because the patient has not hemodynamically collapsed. They have a pulse. They are kind of slurring and responding to you. They're not completely responsive, but they're not completely unresponsive. They are breathing and their heart is beating. So CPR wouldn't be an option in this case. If they deteriorate further, definitely. Okay. So your nurse turns up and you've asked for all of your standard investigations and observations, get an ECG, check pupils. Great. Pupils normal, equal, and reactive to light. If they were pinpoint, you'd be thinking about potentially an opiate overdose or something like that. If they were dilated, you could be thinking about alcohol abuse or any kind of substances. It's a great suggestion. I then asked the interviewer, so I've got a bit closer to the patient. I'm trying to listen to their breathing and get a bit of better and use all of your senses. So I asked them, what can I smell? Can I smell alcohol? And they say, no, you don't smell alcohol on the patient at all, but you do smell a fruity odor. Does anybody have any suggestions with that information? Wonderful. Someone said DKA. That's what I wanted to hear. Diabetic ketoacidosis. So this is exactly what I said. I said, okay, I think this is a DKA given the presentation. I would try and get hold of the patient's ID and run a search on their medical history. I'd also get a capillary blood gas. So I asked the nurse to get a capillary blood gas and it comes out at 34. So what would you ask for next? So the glycemia is 34. So the next thing I would ask for is ketones. That's another bedside test. And if their ketones are above 3, that is one of the diagnostic criteria. So the diagnostic criteria for DKA is they need a glycemia over 10, ketones over 3, and they need to be acidotic. Okay? So you get their ketones, and the ketones are like 4 or 5. They're high, they're raised. So this is now DKA until proven otherwise. So DKA treatment would involve getting a bag of fluids up, monitoring the patient's acidemia, because you haven't taken a blood gas yet, so you should ideally take a blood gas and run it. And you need to give the patient some insulin. So all trusts will have what's called a fixed rate insulin infusion. And this is a printed A4 proforma that you just sign, and it starts a titrated dose of insulin, potassium, and glucose. Because once the patient's DKA is beginning to be treated, their glucose will start dropping, but they'll still be acidotic and using ketogenesis. So you'll need to be giving them glucose alongside the insulin. This is not something I'm expecting any of you to know. There's a couple of graduates in 6 years. You should have an idea. But that will be the treatment going forwards. And you just need to know that that's something that you can start a patient on. So someone said, give glucose intravenous. I wouldn't start with glucose intravenously because the problem is that the glucose is high, okay? So you need to bring the glucose down, and then only because you need to keep giving insulin to reduce the ketones, you'd also give glucose. But this is technical stuff that you will learn in internal med if you haven't done it already. There's a really good mnemonic that I use for DKA. It's called FigPick. So I'm going to write it down in the chat. So, oh wait. That wasn't to everyone. Right. So FigPick just means you give fluids, insulin, monitor the glucose. P is for potassium, because if you give a patient IV insulin, their potassium will drop. So you need to keep a very close eye on their potassium and supplement when necessary. I is for infection, because infection is normally the trigger for DKA, but it's infection or any other trigger. So you need to be aware that although you're treating a DKA, it could have been triggered by an infection. So as the patient begins recovering from the DKA, you also need to treat the underlying cause. C is chart fluids, which is just keep an accurate fluid intake and glucose monitoring. And K is for ketones. So they're all just, it's a good way to make sure you've ticked all of the boxes, okay? And that's literally all they're looking for in an interview, that you can recognize an unwell patient, keep yourself safe, do the basic examination and know when to call for help, okay? The thing that they're most keen on finding out during interview is that you are able to escalate appropriately. Okay, if you don't know how to treat something, that's fine. But I see patients every single day that I have no idea what to do with. But it's knowing who and when to ask for help that is the key. Okay. So hopefully, one of the more senior students in the chat, and that's 5th year and above, or any 4th years that I think they might want to, I think you should try and do an S-bar handover for this patient when a senior doctor has now come to help you. It feels really scary. It doesn't need to be perfect. You just need to get the information across, and it's really good to get in the practice of doing these things. Okay. So if anybody wants to type it, that's also fine. Just please let me know that you're typing so I don't pick on someone in the meantime. Or you can unmute and just talk. I'm very open to that as well. I'm going to pick on Mariam. Sorry. I'm happy for you to type at me if you'd rather, but I think it would be really good if somebody can give an SBAR that then I can give feedback on.
No, sure, I don't mind. So we have a patient here who was in diabetic ketoacidosis. We checked his blood gas levels and his ketones. We did ascertain that, yeah, he was in ketoacidosis. And did we treat him or we did not?
We started him on treatment.
Okay, yeah, we started him on treatment, and yeah, I would just recommend that you keep him like monitored, and that's about it.
Okay.
No other recommendation, I guess.
Okay. That was really good. I would just add personally into the SBAR that I've started the patient on treatment. I'd appreciate if you could review them and see if there's any further treatment required, because you've only treated the initial problem, and fixed rate insulin it'll help the patient initially, but it won't go on to help them. But that's not something I necessarily expect you to know. It's just to bear in mind that in SBAR, the R doesn't always have to be a recommendation. It can just be request. And quite often, especially as an F1 and F2, your request is, please, can a senior come and review this patient? Okay, because if a patient is this unwell, I would want a more senior doctor to review them, even if I believe they're on the correct treatment. Okay. Your handover was really, really good. The only thing I would say is when you said we have a patient in DKA, you don't need to justify what the things that you've done to come to that conclusion. You saying the patient is in DKA is enough. You don't need to say, we check this, we check this, we check this. It's only if you want to give a certain lab value, just because it takes a little bit longer to say. Okay. So, thank you for listening. I'm sorry if this was a little bit brutal. I just feel it's a slightly better way to learn. These are my top tips for interviews, applying for jobs, applying for placements, anything like that. I tried to leave 10 minutes at the end if anybody has any questions, either about the cases, about interviews in general, about working as a junior doctor in the UK. I am very happy to talk to you. I have literally only been a doctor for 6 months, so I appreciate that you all think I'm scary, but I was sat in your shoes not even 6 months ago. And if you've got any questions about what's on the slide, that's also fine, just let me know. And I'm happy to be messaged privately as well.
How did you find the transition from learning in Czech to being a doctor in the UK?
It was okay, to be honest. I started on a really, really busy ward, so it was slight trial by fire, but a lot of it is just about knowing your limitations and knowing who you can go to for help. So knowing, when it's appropriate to escalate something just to the F2, when it's appropriate to say, okay, no, we need like a registrar to come and review this patient. I think making sure you're familiar with the NHS system will make a massive, massive difference. I did a lot of placements in the UK while I was studying, and I appreciate that's not always possible from a visa point of view, but just learning about kind of the different hierarchy in the UK, because the pattern of escalation and the seniority of doctors is quite different. And I think from a soft skills and interpersonal skills point of view, that's what made the biggest difference. In terms of actual clinical knowledge, we know a lot. Like, as much as studying the Czech Republic feels ridiculous, our theoretical knowledge is really, really sound. You just have to trust yourself to apply that practically. And that's really difficult. It took me, I think, a good 2-3 months to actually be okay treating patients independently. And that's fine. I used to just tell seniors when I started on the ward, like, I'm happy to see patients independently, but I'd like to discuss all of my treatment plans with you. And they'd always say, yeah, that's fine. I've never, ever had a doctor of any grade in any situation say to me, no, you need to do this independently. And I don't believe for a second anybody would ever say that to a foundation doctor. And if they do, I'm fairly sure that you could put a complaint in against them because it's not safe. where was I asked to do an SBAR in the interview? I was asked to hand my patient over. I wasn't specifically asked to do an SBAR, but I feel SBAR is very widely used in the UK. It's been used in every single hospital I've ever done a placement in, and I think it's a pretty good model. Whenever I do ward handovers, like at the end of night shifts and I'm really tired, if I don't SBAR, I just kind of ramble and it's a bit pointless. So if you don't like SBAR, that's fine, but just have a symbol, something that you're going to use. Are there any NHS trusts where you'd recommend doing a placement? Okay, everybody hates my answer to this question, which is the best NHS trust to do a placement is the one that gives one to you. I used to just go on the internet and find email addresses for consultants in any random hospital and just send them my CV and like a 2-paragraph cover email saying, hi, I'm really interested in your specialty because of insert random reason here. I'd be really interested to join you for a clinical attachment. I'm available between these dates. Please see my CV below. I'm available to be contacted for further discussion. And I think in third year, I sent like 300 or 400 emails. It's just about finding that one consultant that's willing to agree. I've done placements in lots of different trusts. I think it's probably slightly easier in a district general as opposed to a tertiary referral center, just because they already have less students. Whereas when I've done them in a tertiary referral, you're kind of battling with medical students here. But if you do it over summer, that's not an issue. Just think about convenience. If you've got a 2-hour commute, you're going to hate the placement regardless. So I'm sorry I can't give you specifics, but it's just brute force and doing what you can. I can let you know some of the ones I did my placements at, but I don't think it's going to make a difference, to be honest. Do new doctors take more than 2-3 months to treat patients independently too? I think treating patients independently is a lot of a sliding scale, and it depends how confident you are in the patient that you're treating. So I've had patients that have come in with kind of a glaringly obvious pneumonia with raised white cells, crackles on one side, a consolidation on the chest x-ray on that side. And I'm happy to give them antibiotics on their own because I'm confident in my diagnosis and I'm confident in that. But I'll always still kind of just discuss it with a senior, even if informally. If a patient's complex, I absolutely would not treat them independently. But you would definitely be expected to be reviewing patients independently. So I was going to see the patient doing clinical assessment, and then you wouldn't necessarily make the plan individually, but you would be able to assess the patient independently after 3 months, definitely. And it sounds scary, but honestly, after a month or 2, you'll be there anyway. You pick it up a lot faster. How long should the SBAR be? Yeah, just a few sentences, a minute, maybe 2 minutes. It's not, I try and keep it to a sentence per section. So a sentence on situation, a sentence on background, a sentence on action, a sentence on recommendation or request. The variation being if a patient is particularly unwell and they have a particular lab test or a particular thing I'm concerned about, I'll start the phone call with, I want you to come and review this patient and then do SBA, just because it sets the tone slightly different. Would you have any tips for interview when dealing with the clinical scenario? Yeah, so the clinical scenarios, the reason I did these 2 cases is this is exactly how I would approach them at interview. And I was given really good feedback from my DKA patient interview, and that I approached them in a safe and effective manner. So it's just about going through your ABCE assessment and making sure you know who and when to escalate to. The Oxford Handbook of Medicine, the yellow, people call it the cheese and onion, it's like a bright yellow book. It has a section at the back on like medical emergencies. Just learn those flowcharts inside out. I've done maybe 15, 20 interviews, and that's not normal. That's because I've applied for jobs last year and this year. So over 2 years, I've done about 15 or 20 interviews, and I've never had a clinical case not from that section. And I've never heard of any of my friends having a clinical case not from that section. So that's what I'd recommend. Quite a lot of people also got ethical scenarios. So I'd recommend reading the GMC's Good Medical Practice, which looks at ethics and safeguarding. So you'll get, you come into work and you think your senior doctor's drunk, what do? You think there's a safeguarding, you're concerned that a patient is unsafe at home because you think they might be in an abusive relationship, and you just need to know about the safeguarding protocols, which are quite specific to the UK. So I just make sure you look up safeguarding as a concept. In terms of interview, there's a medical interviews book. It has loads of like squares on the front. I can send the organizers a link and they'll send it out. That's quite good for structuring the please take me through your CV question. And I still use this format when I'm talking to people that I want placements and jobs from, and it's camp. It's talk about your clinical achievements, academic achievements, management and audit, and then a personal aspect. And I just find these frameworks make your answers look a lot more polished. I would just do some interview practice. It's shit, it sucks, but it helps. Yeah, that's mainly what I'd say for interview. Just have your clinical stuff down, have your CV down. And if you've got gaps in your CV, just make sure you have an answer for them. It's not necessarily the gap, it's whether or not you have an explanation for it. So for example, I didn't have a published audit when I graduated from medical school. And I said, whilst I have a good understanding of QIPs and it's something that I'm looking into doing, I've not been able to do that within the Czech healthcare system. However, I appreciate that they're important because, and then went on through to show that I know the theory of how to do an audit, even though I haven't done one. How did you go about applying for a job and when? $1 million question. So I started looking at jobs in January, February, which was probably too early, to be honest. Most of the jobs come out in like March, mainly April, May. And I would just check NHS jobs every single day. Oh, actually, that's a lie. St. Helens and the Knowsley, which is a trust in Liverpool, I think opened their applications in late December, but that was the earliest by far. Most of them are coming up kind of around now. And the really great thing about NHS jobs or track jobs is once you fill in the application once, and your first application should take you a good 2-3 hours, the bulk of it can just be copied, pasted and reused later. So your first one will take you 2-3 hours, but then every subsequent application should only take 20 minutes, half an hour. And I just set aside a particular time in my revision schedule that like, okay, for this hour, I'm going to check NHS jobs and apply to any of the jobs that I think would be good. There are loads of clinical fellow jobs. It is up to you whether you feel you should be applying for an F1 or an F2. A lot of the F2 jobs will just straight reject you if you haven't worked before, and that's fine. St. Helen and the Knowsley interviews in Brno normally. The Great Western interviews in Prague normally, and they tend to be a bit later. So St. Helen and the Knowsley, I think, interviewed in maybe January, February, just for peds. The Great Western interviewed very late, I would say late May. But there are lots of different trusts. I know you've all heard your seniors go to Swindon or go to Liverpool or go to Plymouth, but you don't have to stick to those hospitals. There are pros and cons of doing so. But just keep your mind open. My approach was I just applied to anything that looked interesting. I got rejected from most of them. I got some interviews from some of them, and even the ones I got rejected from, I got some really good interview feedback from, and that's helped me a lot this year. The other thing to consider is F2 standalone, which I think they've changed it. So whilst you can apply if you've not worked in the UK, you almost definitely won't get a job, but the applications for that open in October, so you need to be really on it. No, not having done an elective in the UK is not a deal breaker at all. You just need to be able to explain that you have an understanding of the NHS. I know plenty of people who've never done a UK placement who have a job in the UK right now. It's just about making sure you have another way to show that you understand the NHS and another reason for wanting to come to the UK. You will almost definitely get asked why you want to come to the UK.
Sorry, you said that you applied to F1, but I did read somewhere on the GMC website that if you're coming from Czech, you can't apply to F1. So how did you go about doing that?
So I'm not going to talk about me because I did some weird stuff with applying. But we graduate from Charles University with full GMC registration, which means we're not eligible to apply for F1 training. And you can go into a standalone F2, but that is a whole separate lecture, essentially. what I did is I applied for clinical fellow jobs, which are non-training jobs at F1 or F2 level. So functionally, my job is that of an F1 to some extent, but I'm not on the F1 training program. So applying through national recruitment as an F1 means you'd be applying with all of the British medical students, and we are technically overqualified to do that. So you apply for trust grade jobs. So what you're looking for on NHS jobs is trust grade jobs, clinical fellow positions, junior clinical fellow at F1, F2 kind of level. Does that make a little bit of sense?
Yeah, it does. Perfect. Thank you.
No worries. Do we have any more questions? No? No, so junior clinical fellow positions at F1, this is not something you'd ask at interview. This is something that would be stated on the job that you're applying for. So it would say junior clinical fellow and then like in brackets, normally F2 or F1 equivalent or something like that. So it will be written in the job description somewhere what level it's at, if not in the title. It's not something you'd request at interview. No worries. Yeah. Okay. If we don't have any more questions, I think we'd be done for today. It'd be really great if you could give UIMS your feedback and let them know if you'd like some more interactive type talks, or whether you felt I was really mean and you'd rather I never ask questions. Then I won't ask questions next time.
I actually have a feedback form that you guys can scan the QR.
Okay, let me stop sharing.
Okay. Let me see if I can do that. It's not letting me share.
Do you want to send it to me and I can just share it from my screen then?
Yes, I can do that.
Yeah, I'll send it in the chat as well. I'm just waiting for the link to come through.
Perfect. If you guys scan that QR code, you'll get to fill out a feedback form, but after you fill out the feedback form, you'll get a certificate for attendance. Has that come through?
But are you able to put the link in the chat? I don't think I can do that while I'm screen sharing. Ta-da!
Perfect. After you scan the QR code, you guys can leave. I'll end the recording now. Thank you all for joining. And thank you for the lecture. It's been very, very insightful.
Right.